to the melanoma community. Please be patient with us as we navigate this new way of communicating, but I think it's going to be incredibly powerful. As Patrick said, I'm Sancy Leachman, and I'm the director of the Melanoma and Skin Cancer Program here at OHSU, and also the principal investigator of the War on Melanoma program, which is where a lot of you probably got your invitation. So I just wanted to start off with the purpose for this meeting, because I think it's always important for everyone to sort of have that common purpose. The purpose of our meeting is to acknowledge that these are very trying times for everyone. The ability to navigate the system for melanomas can be very confusing, and what we need to work toward is understanding what are the best choices to make in the era of COVID-19. And we're here to talk about those today, and the fundamental principle is that we want to balance the risks of COVID with the risks of getting a melanoma or taking care of a melanoma. And at the end of the day, this can be a tough balance, but we all share the same goal of achieving the best possible outcome for each patient and the larger community. So I'll start off just by saying that at the director level, I've had to become a leader of a team effort that I never anticipated being a part of, much less a leader of. And we've basically converted, just so that everyone knows, we have a very, very active clinical practice, and we've converted that into basically an urgent care only. So only people who absolutely need to be seen, but those people who do need to be seen are seen. And we've worked with leadership around the country to define what urgent really means. What is urgent? What does that really mean? And how do we apply guidelines of care that are appropriate to our own institution for the benefit of each patient? Our basic science labs have been completely shut down. Our clinical trials operations have been cut back. Our administration has been working overtime to make sure that the daily adjustments that we need to make to be able to pivot with changing guidance that happens almost daily happens well. And that there's a lot of chaos, but in all of the chaos, we've established a new normal, and I think it's because of everyone's willingness to work together, with the patient, of course, as our North Star. So I'd like to, that's basically what I've been going through, and I'd like to now introduce several of the panelists that are on the call today on the WebEx, so that you know who they are and who to direct your questions to, and also so that they can very briefly summarize what they do in our program and how their daily activities have changed because of COVID-19. So I'm going to run this in order of sort of stage of diagnosis of melanoma. So we'll start with a couple of dermatologists. Let's start with Elizabeth Berry, who is the director of our pigmented lesion clinic. Elizabeth, can you come on and tell us about yourself and who you are and how things have changed?
Hi, I'm Elizabeth Berry. As Sancy Leachman said, I'm the director of our pigmented lesions clinic and in charge of finding melanomas as early as possible. And so I see a number of you on the call that are familiar, and we're all in this together. So our daily practice, like Dr. Leachman was saying, has changed to triage based, where we're only seeing what's urgent or emergent and really trying to figure that out. But I want to reassure you it's a dynamic discussion, and that nobody with a clinical lesion that they're worried about gets missed. And we have ways to triage those through teledermatology to ensure that we're only bringing in the people who absolutely have to, because number one, first and foremost, we want to protect you from the virus and keep you safe. But number two, we don't want to miss anything. And so we're really working hard and overtime to ensure that we're taking care of people the best way possible.
Thanks, Liz. So we have a couple of other dermatologists that we'll get to in a minute. I wanted to go next to our dermatologic surgeon, Anna Barr. Could you do the same?
Hi, everyone. Thank you for tuning in. I'm Dr. Anna Barr, and my practice is primarily focused on surgical treatment of skin cancers, which include usually basal cell carcinoma, squamous cell carcinoma, and melanomas. Particularly for melanomas, since that's what we're discussing today, we want to reach out to you and assure you that we are still going to be treating melanomas to whatever extent is possible under these circumstances. And primarily the treatments that we offer in dermatologic surgery are local anesthesia treatments, meaning that they're not in the operating room. They're excisions with local anesthesia. And for the face, we usually do a Mohs procedure for locally invasive or shallow melanomas. So primarily we're an outpatient surgical department that's not in the so-called operating room where the patients are still awake. And that's kind of the perspective that I'm representing here at today's meeting.
Thanks, Anna. Really appreciate it. Okay, let's go to a surgical oncologist, Dr. Hahn, Dale Hahn. Are you available? There you are. Uh-oh, you're on mute still. Can you unmute? Yep.
I'm not on mute.
Hear you now. We can hear you now.
All right, perfect. I was just saying, always happy to be talking with you. Welcome everyone. As was discussed, our program is really a group effort, and we all work together to try to give the most optimal treatment for all melanoma patients, and that really has come to a focus now with the COVID-19 issues. As Sansa was mentioning, I'm a surgical oncologist. The majority of my practice revolves around melanoma. And what I do for the treatment of melanomas is on several levels. One is treatment of more advanced primaries and performing sentinel node biopsies, management of nodal disease, metastases or disease, management of in-transit disease, and also management of stage 4 metastasectomies in conjunction with medical oncology and dermatology. So at all these levels, COVID-19 has obviously affected how we treat patients with these various levels of disease. And really, it takes a multidisciplinary effort, taking into account different risk factors and assessing which patients we will try to urgently treat. But the big thing to take out of this is that we provide the treatments that you need, and you have a group that is looking over you and knowing when to be able to try to get you into the treatment algorithm. For localized disease, we definitely will utilize Dr. Barr and the Mohs surgeons to try to help treat those localized primaries earlier if needed. But unfortunately, as we're all aware, the operating rooms are at this point shut down to any elective cases. So one of the big things we've had to do is to try to triage cases to know when we can bring urgent cases to the operating room. We still do that, but certainly not to the volume that we were doing prior to the COVID-19 pandemic. So, triaging patients for the operating room is one of the big things we do as a multidisciplinary group to try to bring the most optimal management to those who need it right at this point, and to know that we can still have those patients who can wait a little bit longer to make sure that they are well in the system to be able to get the treatment that they need.
Thanks, Dale. Really appreciate your comments. I'm sure that's going to be of interest to a lot of the listeners. I'd like to go ahead now and introduce someone else who is not a practitioner of medicine, but she is a basic scientist, Pamela Cassidy, because this is not only affecting our clinical practice, it's affecting both our basic and our translational science. And so, Pam, would you mind introducing yourself and telling us how that's affected you?
Hi, this is Pam Cassidy. As Dr. Leachman said, I'm a basic scientist. I'm trained as a medicinal chemist, and I've been working with Sansi for many years on coming up with new ways to take our understanding of the risk factors for melanoma and translate them into medications that we can give to people to lower their risk for the disease. And this has been a pretty trying time for us because we've had to close down the research labs, and not only is that a lot of work, but it introduces a lot of uncertainty as to when we're going to be able to continue doing this work that all of you can certainly appreciate is very important. But we remain dedicated to getting back in the lab as soon as we can, as soon as it's safe, and starting back with our research on this topic that's really very important. So thank you all for having me here.
Thanks, Pam. So I'd like to also introduce a couple of other dermatologists. The first one is Dr. Alexander Witkowski. Are you there, Alexander? Do you want to tell them just briefly who you are, what you do, and maybe keep the other rest of it short?
Absolutely. Can everybody see me?
Yes.
Okay, great. Hi, yes, I'm Dr. Alexander Witkowski. I'm a new faculty here at OHSU. I'm the director of the Skin Cancer Imaging Center that we've just launched here early this year. We're focusing on providing patients with virtual biopsies after they've been pre-screened by other dermatologists or with us in our imaging center with dermatoscopy. So the virtual biopsy that we offer patients, it's a confocal microscope that allows us to see the cells live at the patient bedside. So as opposed to a traditional injection with an anesthetic and then cutting, we're able to do this optically and visually and without any pain at the bedside and make decisions on the spot, or if another provider will refer to us, those decisions will be made within about 24 to 48 hours. So we're trying to use this technology, or we are using the technology in order to not only catch skin cancer at its earliest phases due to the ability to see the cells in vivo at the patient bedside, but also reduce biopsies by about 50% of patients.
Okay, thanks, Alexander. Appreciate it. I think there's another dermatologic scientist on, Dr. Raj Kulkarni. Do you want to say a couple of words about the particular, what you do and the particular way that this is impacting you?
Yeah, so thanks, Nancy. I'm Dr. Raj Kulkarni. I'm a clinical dermatologist as well, just like Dr. Berry and Witkowski and Dr. Leachman. But I also do a lot of work with translational research. So getting melanoma specimens from patients, getting biopsies, and really trying to understand both the biology of the specimens as well as some of the treatment options, including things like immunotherapy. And one of the areas that we've been focusing on recently was in understanding some of the side effects, like skin rashes and so forth, that occur secondary to giving some of the newer immunotherapy medications. And as Dr. Pam Cassidy mentioned, a lot of the research so far has been suspended due to the COVID pandemic, and we have, sort of done similarly, and we're eagerly awaiting when we can restart some of these vital efforts as soon as things are safe to return to that. But in the meanwhile, as everyone has mentioned, we are still seeing the urgent patients. I primarily practice at our affiliated Veterans Hospital, and I was in clinic this morning and saw a couple patients again for urgent biopsies to be done. So we're still, trying to do the best to triage appropriately and make sure that those that need urgent attention are given that attention.
Thanks, Raj. Really appreciate it. And now I'd like to introduce Amy Cohn. Amy, if you can just say a little bit about, who you are, what you do in the program, and how this, the COVID-19 has affected your practice.
Thank you. So I am with medical oncology, so directing more of the systemic therapies. In terms of how COVID-19 has affected things, in different ways. So clinical trials are still active. They're a little bit curtailed in the sense that some things that we consider as not essential that we would normally be doing are eliminated, but nothing that impacts patient care. So all of the opportunities are really still there. I think one trial has been placed on hold by the sponsor. In terms of being able to see patients, that really hasn't been a problem, and still doing it using the phone or virtual or in person, depending on what works for the individual, and still accommodating the urgent follow-up and able to continue to move forward. I think probably the other impact is synergizing a little differently with surgery, in the sense that where it makes more sense to put off surgery a little bit, then we can use some of the systemic therapies as a bridge to make sure we're still supporting appropriate treatment.
Thanks, Amy. Really appreciate it. So I think at this point, are there any other providers or panelists that are on that would like to introduce yourself? I didn't want to miss anybody that wanted to let themselves know. So let's go on. Now I think everybody knows who the people are that are available for questions. And I want to go forward now with asking a few questions of our panelists. I want to remind everyone that's on the call, if you have a question that you'd like to ask really quickly, then if you can enter it into the chat, and Patrick will then raise some of those questions to our attention so that we can answer them. I want to start with some that were pre-sent to us. And we'll see how far down the road we get. First one was, what treatments are being prioritized or deprioritized? And I think I'd love to hear Amy, since you're the last one that spoke, if you could maybe start by telling us about the medical oncology treatments, and then maybe we can go to Liz and to Dale for the and dermatologic treatments. Maybe Anna Barr too would be able to tell us about the surgical treatments too. So Amy, can you tell us a little bit about what treatments you're prioritizing or deprioritizing?
Probably the biggest one that I would say I've been deprioritizing. So we have one trial, Keynote 716, which is for stage 2 melanoma, with the question of whether adjuvant therapy is helpful, where people would be getting immunotherapy versus placebo. And in that setting, with the risk of needing to come in for infusions, uncertain side effects, you don't know if you're getting medication or placebo. In the context of this study, where if someone's in the midst of treatment, we're allowed to hold for 12 weeks. So that's probably the biggest one where I've put less emphasis because of concerns about risk of treatment in this setting relative to risk of disease. Everything else, I think, I think, of course, the more advanced the melanoma, meaning there's more significant lymph node involvement, more detecting metastases, those are still viewed as urgent and accommodated that way.
Thanks very much. That's really great. I did hear from someone, Dr. Joanna Ludzik is also on the line. So I'd like, Joanna, if you could please introduce yourself as well. And then we'll just move on quickly to Dale and Anna.
Hi, I'm Joanna Ludzik. I'm new faculty here. I'm really happy to be here with you today. And like Alex mentioned before, our focus is on dermoscopy and confocal reflectance microscopy, and we would like to implement this modern technology into our clinic.
Wonderful. Nice to meet you too. All right, so Dale and Anna, we'll go with Dale first. How has our treatments being prioritized or deprioritized in certain ways? That, I mean, our patients want to know, right? What is how's that working?
Absolutely. So, the one thing I wanted to just make sure everyone knows is that all melanomas are a priority to us. It's just more of, the algorithm that we're kind of funneling patients into may be a little bit different. And as Amy mentioned, for more advanced stages, if patients are not candidates for some kind of systemic therapy or other kind of therapy that we can utilize to try to optimize outcomes, we may be able to get those cases on as an urgent case to start off with surgery. But in many of the cases at this point, especially those patients who may present with a enlarged lymph node or low volume disease for stage 4 disease, we'll basically start with a neoadjuvant or upfront systemic therapy approach. And Amy, I've shared a number of patients already in the past couple of weeks, going down this road. And as she mentioned, for patients with localized disease or who present with localized disease, it then becomes understanding what's the risk percentage of having or detecting, let's say, melanoma that is spread to the lymph nodes, what we term a sentinel node. And we as a program have just started to come up with our algorithm, or developed an algorithm, and we basically designated a certain percentage point, at which point we think patients are at high enough risk, we're going to turn this urgent and get that into the operating room. Whereas those patients who are less than a certain risk, a low risk, we either have surgery for the primary site, either through the dermatologic surgeons or with us, or in the procedure room, or again up in the dermatology suites for the Mohs surgeons. Or we delay sentinel node biopsy after that primary is treated initially. So there are multiple algorithms, and the big thing is trying to figure out which algorithm patients will be able to go down to continue to optimize outcomes afterwards. I'm sorry, Santi, you cut out.
Okay, I just said thank you very much. Appreciate and I would like to go now, if possible, to Anna Barr, Dr. Barr. If you could tell us, how are melanoma cases being prioritized, and are there any that we're holding off on because we believe it's safer for the patient?
So because we are not using operating rooms, we are still doing surgery on early stage melanomas because we don't believe that delaying those is a real good idea at this time if they can be safely done under local anesthesia with no use of operating room resources. So what that means is melanomas that don't require a sentinel node biopsy. We've changed our operating practices. So for those of you who have been in derm surgery before, there's no more waiting room. There's no more sitting out in a waiting room with other patients. Basically, when a patient comes in, they're escorted directly to their private room, and they remain in their private room for the entire extent of the time. So while we're testing their tissue to make sure we removed all the melanoma, they don't go out to the waiting room. They just stay in their private room. We feel that we can completely minimize all exposures when there's no interaction with any other patients and no waiting in the waiting room. So luckily, we've been able to continue to take care of the early stage melanomas. And I think that we're all hopeful that Dr. Hahn and Dr. Vedo will be able to resume taking care of the melanomas that require a sentinel node biopsy, hopefully within a month. I think we're all hopeful about that.
Thanks, Anna. I appreciate it. And any of the dermatologists, have you guys, how have you deprioritized, or how have you made that call about who we will see in terms of our melanoma patients and who we haven't? I think you sort of summarized that a little bit already, Liz, so maybe not much to say, but anything else? The patients, I think, probably want to know when does the risk of having a problem outweigh the risk of getting a COVID-19 infection? And I think having the dermatologists talk a little, just briefly, about that might be something they want to hear about from the questions we've received.
I'll go ahead and start because I introduced the topic, but I just want to reassure you all that we're going through our schedules actively, and I'm reviewing every patient who has a history of melanoma and trying to decide, okay, well, what are we following? Were there moles we photographed? Is there anything that I was worried about on your last exam? When was your prior melanoma? And trying to gauge along with that anybody else's, what additional comorbidities do you have? Meaning, do you have diabetes? Are you over the age of 65? Those sorts of things that might put somebody at higher risk for getting a severe COVID infection. And trying to very carefully weigh out, can I extend this person's follow-up another couple of months, or is it worth bringing them in? And I'm trying to make sure that anybody who's coming in for their oncology appointment with Dr. Cohn, that we're going ahead and knocking out their skin exam, because she and I practice in the same space, and I practice in the same space with Dr. Hahn as well. And just trying to go through that risk benefit analysis. But we're also going through, and one of my very dear nursing staff is going through and calling each of our melanoma patients or messaging them and making sure they're all hooked up. They know what phone number to call. They know that they can sign up for our MyChart system, which is our direct messaging system, so that if there's a problem, if there's anything that you guys are concerned about, you can get in contact with us. And then our first level of triage is usually having a person sent photos through MyChart and scheduling a virtual visit, because we can get quite a bit of information through there. And we're doing this with new patients as well, because when somebody says, I have something that's rapidly growing and it's different colors, we need to see that and need to try to see that before bringing somebody in, because there are a number of other benign things that can sort of mimic that behavior. And then I want to turn it over to Dr. Witkowski and Dr. Ludzig, because they've come up with a really clever way of giving us some additional information remotely that we would love to have, because we all use our dermatoscopes, which are these you see these handheld devices that have magnification and polarized light that give us tons more information about moles and what's changing and what's different. And so they've come up with a kind of a clever stopgap between seeing something on our teledermatology and bringing somebody in immediately.
Thank you very much, Dr. Berry, for introducing the topic. So I want to kind of go into what are the available options that we have as of today, and what are kind of things that we're working on together as a team to improve efficiency and precision. So as of today, of course, I want to reiterate that any moles that you have or skin lesions that are rapidly growing, changing in their shape, size, and color, and especially if they're firm and nodular, we ask you, please, this is something that will outweigh the risk of obtaining infection by the COVID-19. So we ask you first to send those photos by MyChart with your smartphone. First of all, you can communicate with your provider directly from the melanoma team, and then we'll send you a special link with instructions how to take the clinical photos at the highest clarity possible. Although we've been doing this for some time already with patients over the last month, we have come into a couple of hurdles in about 40 to 50% of our patients, with the first set of images being unclear due to unclear photos taken with a smartphone. And even if we have clear photos, sometimes we're not able to make a decision, since, as you've already had experience with one of your providers using dermoscopy as an actual initial screening for your moles, we don't currently have dermoscopy available through MyChart when you, as patients, submit your photos. And so we're working on a pilot project right with patients who qualify, especially those with high risk and with a history of melanoma, that we're lending out at-home dermatoscopes that you can attach to your smartphone and then take a dermoscopy image, which is pretty much or nearly as identical as what we can see in the clinic. And so that way you could send that photo and avoid coming in during this crisis. And so we're working on this with a couple of patients already with very good results. About half of the patients after using the device have not had to come in. So we've reduced the urgent inpatient visits by about 50%, even after good clinical photography. And then those patients who have come in, some of them have on their own identified changes that had to be addressed immediately and urgently. And those risks definitely outweighed the chance of obtaining this viral infection, especially in the case of one patient with a melanoma that they found recently on their own and several basal cell carcinomas. I will let Dr. Leachman kind of talk more about that, but in regards to how to become qualified, I think that we'd like to offer this to all of our patient population in the near future. But if you do have any moles now that you're worried about, please do reach out to us and just ask if you can obtain a at-home dermatoscope for this kind of pilot project, and we'd be glad to try to involve you while we're piloting this new endeavor and this new pathway for us in the virtual visits.
Thanks, Alexander.
Sancy, I was gonna go to a question.
Yeah.
And they're a little bit related. One, because while the audience for this is a lot of OHSU patients, we do have some people outside. So I guess first part of the question is how are these guidelines that sort of have come to be formed? Has it been at an institutional level here, or if they're having care elsewhere, is there some sort of like governing body? And if they aren't a patient of OHSU, you know, maybe some tips or tools on how to navigate maybe within their system, you know, ways to get sort of answers, you know, for non-OHSU patients.
Yeah. Thanks, Patrick. I think that's a great question. That was actually the next question I was going to ask too. So I think that clearly there are national guidelines that have been drafted and put into place by in an effort to really make sure that we're similarly thinking about the way to have the best benefit for the patients overall. And I think that we have been talking a lot about what we're doing, and those by and large are following the national guidelines. I guess I would ask Dr. Hahn if you have any comments, any additional comments about places that we may be, if there's anything that we're doing that is not exactly like the guidelines, or if we're following, if the things that everybody has heard here are pretty on track with what we've been recommended nationally.
That's an excellent question. And one of the things we have to keep in mind is that this is an evolving process as things change, as the COVID-19 issues continue on. But the NCCN guidelines that have been created and formulated by some very, very good people have taken into account a lot of the literature and data that's out there. And many of the institutions, particularly those who are NCCN designated as ours is, have adhered to these guidelines very well. They do give very specific things in certain circumstances, but they do give quite a bit of wiggle room, which allows institutions to adjust certain nuances as needed depending on the requirements in that region. From our perspective, we have adhered very well to the NCCN guidelines, although we have adapted certain small areas to adjust for our regional requirements. And I think we really do serve as a role model for other institutions across the region, Pacific Northwest, in terms of how to be able to account for delays, to know how to triage patients, to be able to get patients what they need for treatment, while also minimizing the risk for COVID-19 and the risks for the melanoma. So I would say we're doing a very good job following the NCCN guidelines. And we also are tweaking them in areas where there's a little bit of wiggle room to account for things that we need to do regionally.
Yeah, I think that that's an important point, is that we really do, we want to do our best to make sure that everybody understands their guidelines. And guidelines are really important to have founding principles, but every individual needs to be taken into consideration as well. And there certainly are exceptions to any guideline, and that can happen if you're an individual that falls between those cracks. And so we're not applying guidelines to the exclusion of common sense. I think is a really good way to think about it. I have a really great question from the mailbag from the people who are sending a question. It says, what lessons have you learned recently from current ongoing clinical trials? Are there any recent unpublished data from ongoing clinical trials that are promising for movement into regular care? So people are interested in us predicting the future a little bit by using the clinical trials as our window into the future, our crystal ball. I think I'd like to open that to Amy if she's available to talk a little bit about what she thinks is going on that's really hot and really exciting. Amy, you're still on mute, I think. I'm sorry.
So in terms of what is the direction of melanoma? So I think one is still developing and identifying new targets with additional targeted therapy. I think the other one is along the lines, sort of developing the concept or the principle with a current therapy that we have, which is TVEC. And so we currently have a trial led by Dr. Han using PB10 combined with immunotherapy. So it's very directed therapy to specific lesions combined with immunotherapy, and extending that into other skin cancers. And then, I think it's still trying to optimize the personal therapy. So I think developing vaccines that are specific for an individual's melanoma, and trying to both develop that as well as make sure that it can be broadly applied, or it can be amplified to meet a large volume of patients. I think those are probably the three biggest avenues that are moving forward.
That sounds great. That sounds great. I think that we've also heard a little bit about the trials and the pilots that we're using for diagnostics. Dr. Han, do you have any other comments that you might want to make about any? If trials were your crystal ball, what would you predict is coming in the near future?
I would never have to work again a day of my life. I knew that. So I agree with everything Dr. Cohn said. There are certain major areas that are targets, and really melanoma has been the disease site that has pretty much led the way across the spectrum of cancers. And after 2011, we've had 11 or 12 new FDA-approved regimens or agents. And we're in a little bit of a lag phase right now, or a kind of a quieter quiescent phase, where really the focus is on combination therapies and a couple of new agents on the pipeline. One of the most promising so far is Nectar, and based on the phase 1/2 data, it was very promising with overall response rates that were 53% for combination of Nivo with Nectar, and therefore it's gone into phase 3. Now I don't know what the data is in terms of how well that is. There have been some thoughts as to whether or not it's still holding up to what the phase 1/2 said. Also, there have been some issues with the production of Nectar. But it is a very promising agent. It's one of the big ones that is being touted right now. Other agents like anti-LAG3 are also being evaluated. Looks like it's probably as equivalent to current immunotherapies out there. Other agents like OX40, IDO inhibitors have also been evaluated, but really have not shown better efficacy or better toxicity profiles. And then in terms of targeted therapy, they've been trying to get CDK4 and 6 inhibitors on study, and they have, but the data from those studies have not really panned out. So that's a snapshot into a good number of the agents that have been out there at this point. We do have the Nectar trial here. I know Amy has been running that, and we've accrued quite a few patients. They're in fact about to see if they can get Nectar into the adjuvant setting now. There is a clinical trial that they're developing for that. So that pretty much are the agents I know of in the pipeline at this point.
Great, great. I'm going to go to another question from BC. If I have many moles and can't see many of them and often need them biopsied, can I expect to keep my skin check appointment? Skin check by you is my only and best early detection. And I would say yes. We're getting to the point now where as long as we're social distancing properly and there's no need for extra personal protective equipment for the visit, then it's going to be coming back pretty quickly, I think, from here. Certainly, if you have a lesion that is worrisome, as you've heard from everyone else, just let us know. We'll get you in for that. And on the other hand, we're going to start opening it up for high-risk patients. Anybody who's had a melanoma before is considered at higher risk. So we'll be slowly but surely doing that. So yes, I think within the next couple of months, you should be able to have your skin check done, hopefully. That's what we're hoping. I now have a couple of other really, really great questions that all can sort of be lumped into immunotherapy questions. And I think that, so what's really cool is you with immunotherapy, like what Dr. Hahn was talking about, we've sort of led the way in melanoma to a lot of great new immunotherapies. We also have topical immunotherapies. And we also have the question of, if you have received an immunotherapy or are receiving an immunotherapy, does that put you at higher risk for or lower risk for getting a COVID-19 infection if you're exposed? And so I think all of those questions are really, they're sort of tied together, and I'd like to open it up to the panel, maybe starting again with Dr. Cohn, about whether or not you think that if somebody is on an immunotherapy, does that cause you any pause with respect to their risk for getting an infection with COVID-19?
So the short answer is it does. And, I've had this question where one perspective is, if we're souping up the immune system, then is it so souped up that you have, added immunity to other infections? Versus we've souped up the immune system in a way that we don't exactly know. And since some of the complications from COVID are more or as much the inflammatory response, that now we have a souped up immune system ready to respond to the infection. I would err on the side of caution, and I've advised people that I'm seeing that they need to view themselves as high risk and really be extra careful in terms of the physical distancing, not going to the grocery store, do everything they can in terms of someone else going or get deliveries. So my counsel is you have to view it as high risk. The advantage compared to traditional chemotherapy is we don't see the white blood cell count typically go as low, so you don't have that element of risk, but we also don't know exactly what happens when there's an amped up immune system with this kind of infection.
That's great. I wonder, Dr. Kulkarni, are you available to maybe talk about what topical immunotherapies, how do you think that may or may not be relevant to managing people, for example, with melanoma in situ until they can get a surgery or something like that? Or any other thoughts you have?
Yeah, so I think that's a great question. And so going back to sort of what Dr. Cohn has mentioned, in this case, giving the topical immunotherapy something like imiquimod or similar, the goal is to try to amp up a localized immune response. So I think we don't have as much data, just, COVID is so new, but I think there is sort of greater theoretical safety of this kind of approach where you're trying to just get a localized response and try to improve that, but not necessarily get as much of a systemic response in that. So, while we don't necessarily know how things are going to look, that seems to be like a reasonable option, in terms of for right now to try to get a localized control, especially if, a surgery is being delayed, not necessarily here, but in sort of other parts of the country or in other circumstances. So I think that's something that's very reasonable that I know has been discussed. And the question is going to be, for those that utilize that, we'll see what the response are. But I think it's certainly reasonable theoretically as well as from what we understand about the immune system, and should not necessarily cause any increased risks of even in someone with a COVID infection or that gets one while using that treatment. Based on what we understand, there shouldn't be an interaction like that.
Thanks, Raj. So we're sort of getting close. There's a few other questions here that I think are really relevant. One says, as a stage 4 melanoma patient, is sending my husband to the grocery store really helpful for eliminating the risk? If he gets it, odds are I would get it too, right? And I think that it's a really important point. And I think that everyone has been trying to offer the best practices for how we protect ourselves if we're an at-risk person. And certainly things like I think that having him go rather than you is something that decreases risk, but doesn't eliminate it. And having him be very careful when he comes back in after having an outing to make sure that all of his hands are sanitized, to make sure that you let perhaps him open the groceries or allow the groceries to sit for a while. All of those things that you can do to just reduce the risk a bit more is something that you really do need to consider. On the other hand, I also want to encourage people to not let it make you crazy either. An increased risk is just an increased risk. It's not an inevitability. So balance your risks and benefits in the way that seems appropriate for you. I think the next question is there anything you have done with patient care or dosing of medication that you think is better now than pre-COVID and you want to continue past COVID? I think that's a really great question, and I would love for Dr. Berry to give us an answer from the derm, and then maybe a quick answer from surgery and oncologic, medical oncology as well. Dr. Berry?
I think this is a great question and an area that we're actively studying. And there have been a number of a flurry of emails over the weekend about putting together a registry nationwide of basically our patients that we've managed during COVID-19 and figuring out, what was the impact, either, is spreading out care a little bit or dosing things a little bit differently. Is that beneficial? Is it detrimental? We don't know. And it's going to be a little while before we analyze that data. But I think, moving forward, it's, we're really going to be cognizant of how closely we're following people. And I think being able to implement this teledermatology triage has been tremendously helpful from my perspective, because I can get patients in almost immediately for a quick telederm spot check visit, whereas it might have taken a couple of weeks to a couple of months.
I just want to interject there because that's a perfect segue. There's a lot of questions on kind of this general concept of, well, am I going to be able to keep my scheduled appointments in the future? Or if I can't see my provider, what should I do, sort of thing. So maybe we want to try to lump that into maybe some options there.
So I love that question. I think the problem is that we can't answer it. I'm just going to be really honest with you that there's, we have no more control over the governor or the president of the university than any of you do. And so we are in some ways at their mercy. We can't tell you something, and I wouldn't begin to try to tell you something that we don't know. I do know that there is a very good likelihood in our department of dermatology that we will be slowly but surely using appropriate social distancing, we will be opening it up, and that high-risk melanoma patients are going to be at one of the tops of our list of the people who are considered more urgent, because we don't want to get behind on keeping those appointments. I think that's probably true for all of OHSU. I would let Dr. Cohn and then Dr. Hahn quickly answer, but please quickly, because I have a couple of final announcements before we end this session.
So for the first question of have we learned anything about dosing, there's one immunotherapy drug which originally was given every 3 weeks, and there's limited data to say we have latitude to do it every 6 weeks. I don't have a lot of patients getting that because the alternative was already an every 4-week dosing. But that's one area which I think opened up post-COVID versus pre, based on initial early data. In terms of getting people in, I think based on the best evidence we have, or what's been predicted, is that the Oregon surge would be end of April to early May. So I've been hoping that as far as being able to make contact with patients and their regular scans, that by end of May to June, we're at least beginning to get the at least higher risk patients are getting back onto their regular schedule.
That's great. Dale, quickly, anything else?
Yeah, I would just reiterate what was some of the things that are said, like Dr. Barry was mentioning, being able to see patients by telemedicine. Certainly that's an option that is starting to take off more. The operating rooms, we just got contacted that we are going to start in a very limited fashion, potentially opening more cases. Still these cases have to be urgent, but this is a promising sign that maybe we can start rolling in more and more cases. And certainly we're hoping by the end of May, end of May, maybe early June, to be able to be fully rolling cases through. And then just finally is just the integration of multiple services, and knowing that you have the support input of multiple people in a great program to help out in the care of everyone.
Okay, I have one other question. Let's see here. I just got a question regarding support and caregivers, and I guess I feel
I can chime in here, Sancy. Effectively, it was saying due to the more stringent restrictions around who can accompany someone to a patient visit, the caregivers who are playing a vital role in the patient care that could typically attend aren't able to do so. And so, what are some possible solutions or brainstormings on how caregivers can really maintain support even when they can't physically be there?
Yeah, I think that's a really, really tough question, but I think that even just accompanying your partner in the car and remaining in the car is actually quite supportive. I think that little things like helping to get them prepared for their appointment when they're getting ready to go in, to recap immediately after their appointment while things are still fresh in their minds, so that you can help document, do all the things that you would normally have done being in the room. Anyone else want to add a quick 2 cents to that?
I'll just add that smartphones are great. So whichever, even the flip phones, all have the ability to be on speaker. And I more than welcome that. And I think it's great to be able to have the caregiver be able to listen in and hear it directly. And I think to have both sets of ears is very valuable, and still meets an essential component of the caregiver role.
I think that's a great suggestion. Anybody can ask their provider to just let them have a phone call with their significant other. So that's great. All right. Well, so what I'd like to do now, we are almost at time, and I'd like to open it up just really quickly to Kim Funder. She wants to let everybody know about a new volunteer program. And so Kim, do you want to, this is one of our closing 2 items. Anything you'd like to say, Kim?
Yes, hi everybody. I'm Kim, the volunteer coordinator for Melanoma. We have rolled out a really fun and exciting new volunteer program software that is going to be amazing with connecting all of our volunteers throughout the state of Oregon with our team. And within this program, you'll find all the different opportunities we have available that cater to various audiences. You are able to register, you're able to track the volunteer hours that you're doing. We'll also have links to download or order any materials to distribute to the community. But it's also a great way to see what events we have going on that you, if you're interested in volunteering, you can participate in or host or come and visit. And so it's a really great program we have. You could download it into your phone. It's super cool to communicate with us as well as other volunteers. And so we encourage anyone who's looking to get involved further with the War on Melanoma to check out the site, register, and just see if there's anything in it that you'd like to get involved in and spread the word of what we're trying to do.
So Kim, I just will add one other last thing to that before we close, which is that we are going to be sending out a really, really cool baseline survey to everyone to find out what your level of awareness about melanoma actually is. And anybody that wants to take that survey, we'd love to hear what your answers are. And anybody who's not a part of the War on Melanoma can certainly join. It takes about 3 minutes to just join on our website. Just go to the War on Melanoma at OHSU and you can find that. And we'd love to hear, get the answers to that. The final thing that I would say is that anybody who had questions, it looks like Patrick has put up the War on Melanoma site so that we can show you where it is so that you can see how you log on there at the War on Melanoma. Anyone who this has gone very quickly. Actually, I was worried that we weren't going to have enough questions, and we had more than enough questions. Some of those questions have been answered on the chat line. Some of them probably have not, and I'm sure that there are other questions that arose. If you have anything, if you want to send that through our War on Melanoma email, love to have, we will continue to answer your questions through the War on Melanoma email. And if you're interested in doing this again sometime, we'd be happy to do that. We need to know if you have support for it or if this was really not a very successful method for you. Either way, we'd like to hear from you. So please, please do that. And I'm going to turn it over to Patrick Kinghorn one last time to end the session in case there was any closeout information that he wanted to pass on. Patrick, anything else, or are we ready to sign off?
Oh, I think it's great, and no one needs to hear from me, I don't think. There was a lot of questions that we unfortunately didn't get to. Please go ahead and email those to warmelanoma@ohsu.edu. I put it in the chat, and we'll do our best to answer all of those questions. It may take a day or two or three. Things kind of seem to get pushed back as we sort of just take it day by day. But I appreciate everyone joining in, and we may follow up to just see if this was a helpful tool, and to see if you guys want to do more talk on COVID, if you have other topics, and hopefully this can be a really valuable tool that we can use to connect, our melanoma program here with, melanoma patients and caregivers, not just in Oregon, but beyond.
Yeah, so this is an answer to one of the questions. Is there anything else that has happened over the COVID that has made things better? This might be one of them. Having the ability to do these virtual visits might actually be one of the best ways we can get the word out on new things that are happening, better things for patient care, and things that you're interested in hearing about. So if that's true, let us know. And with that, we'll sign off for now. Bye-bye.